today's class is on anti-adrenergic drugs. As the name suggests, these are the drugs that antagonize adrenergic receptors. What are the adrenergic receptors available? Alpha and beta, right? So the drugs which bind and basically antagonize alpha or beta or alpha and beta are called anti-adrenergic drugs. So they are competitive antagonist. Already pharmacokinetics class hoyeche. Antagonism two type hoy, competitive, non-competitive. Others are also there. So it's a competitive antagonist at alpha or beta or both alpha and beta receptors. Now there is a difference between anti-adrenergic drugs and adrenergic neuron blocking drugs. Basically adrenergic neuron blocking drugs, they either modulate the storage or inhibit the storage or release of the catecholamines, while the anti-adrenergic drugs, they bind to the alpha or beta receptors and antagonize them. Example of adrenergic neuron blocking drugs are like reserpine, guanethidine. Okay. Now coming to the alpha-adrenergic blocking drugs, they inhibit adrenergic responses mediated through alpha receptors. So anti-adrenergic drugs can be alpha blockers, can be beta blockers. Alpha blockers basically they inhibit adrenergic response mediated through alpha-adrenergic receptors. Now what are the drugs that antagonize alpha-adrenergic receptors? That include non-equilibrium type blockers and equilibrium type blockers. Among the non-equilibrium type, it is Phenoxybenzamine. So Phenoxybenzamine is a non-selective alpha blocker. Non-selective means it blocks alpha 1 as well as alpha 2 receptors. So it is a non-selective alpha blocker, non-equilibrium type. And equilibrium type, it can be non-selective, that means both alpha 1 and alpha 2, that include ergot alkaloids, ergotamine, ergotoxin, hydrogenated ergot alkaloids, dihydroergotamine, dihydroergotoxin, then phentolamine and chlorpromazine. Among the selective alpha 1 blocker, it is prazosin, terazosin, doxazosin, alfuzosin, tamsulosin and silodosin. Alpha 2 selective, yohimbine. Yohimbine has got no clinical use. Now coming to general effects of alpha blockers. If we know the effect of the alpha response, alpha adrenergic stimulation through alpha receptors, we can make out the general effect of alpha blockers. Now we know alpha blocker, alpha receptor, they cause vasoconstriction and rise in BP. So blockade of vasoconstrictor alpha 1, what does it cause? It causes fall in blood pressure, because there is vasodilatation, there is fall in the total peripheral resistance and diastolic blood pressure falls. Postural reflex is interfered due to venodilatation, there is peripheral pooling of blood. So when a person on prolonged sitting or supine position, when they get up, the postural reflex is interfered, there is hypotension causing dizziness and syncope. And then vasomotor reversal of Dale আমরা পড়েছিলাম আগে, মানে কি vasomotor reversal of Dale? It's a very important question in pharmacology. I said you that on IV injection, intravenous injection of adrenaline, there is a biphasic blood pressure response. Initially there is rise in blood pressure because of beta 1 and alpha 1 action and alpha action, sorry. Now after the concentration of adrenaline start to fall in the body due to the lower concentration of adrenaline around the receptor, beta receptor action is seen. Due to beta 2 mediated vasodilatation, there is fall in blood pressure. That is a normal response seen after intravenous injection of adrenaline. Now what happens before applying adrenaline? If and then we inject after some time adrenaline, then what will happen? Because of alpha blocker, only beta 2 action will be seen, there will be vasodilatation and only fall in blood pressure will be noted. This is vasomotor reversal of Dale. Okay. Now, reflex tachycardia, this is because of the fall in mean arterial blood pressure. Number 1, reflex tachycardia is seen. Number 2, there is increased release of noradrenaline. Alpha 2 block হচ্ছে, alpha 2 কোথায় থাকে? Pre-junctional membrane থাকে, সেটা কাজ কি? ক্যাটেকোলামাইন রিলিজটাকে ইনহিবিট করা, সেন্ট্রাল সিম্প্যাথেটিক আউটফ্লো কমিয়ে দিচ্ছে। নাও as alpha 2 is also inhibited, there is increased noradrenaline release from the junction, so increased release of noradrenaline from the cardiac sympathetic neurons due to blockade of pre-synaptic alpha 2 receptor. Nasal stuffiness can be seen, as already said before. Meiosis are seen because of the alpha blockade in the radial muscle of iris. Intestinal motility is increased, and again there is sodium retention and expansion of blood volume. Because of hypotension produced by the alpha blockers, there is decrease in the renal blood flow. Decrease in renal blood flow, that will decrease the GFR, and hence there is more complete reabsorption of sodium and water from the tubules. That is one one mechanism, and the other mechanism is there is increased release of renin, compensatory increased release of renin from the juxtaglomerular cells, beta action, beta 1 action. So there is sodium retention and expansion of blood volume. Then alpha 1 receptors, as said earlier in the adrenergic class, is located in the prostatic prostatic tissue and in the bladder base. Now what does it cause? It increases the tone of the muscles, smooth muscle there. Now blockade of the alpha 1 receptor, mostly of the alpha 1A type. Alpha 1A অনেক subtype আছে, alpha 1A, alpha 1B, 1C, 1D. In the prostatic tissue and in the bladder base, alpha 1A is predominantly present. Now, so the blockade of alpha 1 receptors, mostly of alpha 1A subtype, urine flow increases in patients of benign hyperplasia of prostate. Now, next, contraction of vas deferens and the seminal vesicles are responsible for ejaculation. Coordinated contraction of vas deferens and seminal vesicles result in ejaculation. Now, what does the drug cause? The alpha blocker inhibit ejaculation by interfering with the contraction of these structures, and that can result to impotence. There is no effect on adrenergic cardiac stimulation. Why? On the heart, only beta 1 receptor is there mainly, so no action on the beta receptor. Alpha blockers we are giving. Bronchodilation কোনো effect নাই, কেন কি bronchial tissue তে bronchial smooth muscle beta 2 receptor আছে, vasodilatation হবে না কেন beta 2 action নেই, and most of the metabolic changes mediated by beta receptors. Now coming to the individual alpha blockers, Phenoxybenzamine. As said earlier, Phenoxybenzamine is a non-selective alpha blocker. It antagonizes in the it's a non-equilibrium type of alpha blocker. So actually in the body it cyclizes spontaneously and form an intermediate called ethylene iminium intermediate. Now this compound, it bind with the alpha receptor covalently, and hence there is non-equilibrium type of antagonism. It develops gradually even after IV injection, and it antagonizes the receptor for about 3 to 4 days till the fresh receptors are synthesized. Partial blockade of serotonin, so it's not completely selective alpha blocker. It can also block serotonergic neurons, serotonergic receptors, histaminergic and muscarinic receptors even at high doses. The fall in BP caused by Phenoxybenzamine is mainly postural. Because venodilatation is more seen with Phenoxybenzamine than arteriolar dilatation. So postural hypotension is more marked. It tends to shift blood from pulmonary to the systemic circulation. Pulmonary bed যতটা কাজ তার থেকে বেশি কাজ কিন্তু systemic circulation এ আসে. It also tends to shift fluid from extravascular to the vascular compartment. The drug is lipid soluble it penetrates the brain and can cause CNS stimulation, nausea and vomiting. Major side effects of phenoxybenzamine: postural hypertension, number 1, impotence, palpitation, nasal blockade, meiosis. Now, it is primarily used in pheochromocytoma. Pheochromocytoma ta ki? অ্যাড্রিনাল মেডুলারি সেল টিউমার রয়েছে যেখান দিয়ে ক্যাটিকোলামাইন বেশি কোয়ান্টিটিতে অ্যারাইজ হয়। সো ইট ইজ প্রাইমারিলি ইউজড ইন pheochromocytoma, occasionally in peripheral vascular disease. Peripheral vascular disease basically due to vasodilatation it improves the symptoms. Now coming to phentolamine. Phentolamine is a competitive type of alpha blocker, non-selective. It's a rapidly acting alpha blocker with shorter duration of action. It's a non-selective alpha 1 and alpha 2 blocker. Now used for the diagnosis and intraoperative management of the pheochromocytoma. Pheochromocytoma diagnose করার জন্য একটা তো বায়োকেমিক্যাল টেস্ট রয়েছে, আমরা 24 আওয়ার ইউরিনারি VMA মেটানেফ্রিন সেগুলো দেখি, দ্যাট দ্য মেটাবোলাইটস অফ ক্যাটিকোলামাইন্স। তার সঙ্গে একটা ফার্মাকোলজিক্যাল টেস্ট রয়েছে কল্ড ফেন্টোলামিন টেস্ট, আমরা আসবো পরে। তো ইউজ ফর দ্য ডায়াগনোসিস অ্যান্ড ইন্ট্রাঅপারেটিভ ম্যানেজমেন্ট অফ pheochromocytoma, control of hypertension on clonidine withdrawal. Clonidine কি করে basically it's a alpha 2 agonist and it increases the release of catecholamines, decreases the release of catecholamines and thus are useful in hypertensive patient. Now sudden withdrawal of the drug can cause severe hypertensive crisis. In those cases basically phentolamine can have a role. So control of hypertension due to clonidine withdrawal, Cheese reaction and others. It is most suitable alpha blocker for local infiltration to avoid vasoconstriction due to extravasated noradrenaline dopamine. In critically ill patient, to increase the blood pressure in shock, we give noradrenaline infusion or dopamine infusion. Now if the drug extravasate in the surrounding tissue, that can cause local vasoconstriction. To counteract that, phentolamine can be a drug. Prazosin. Prazosin is a selective alpha 1 blocker. Now having alpha 1 to alpha 2 selectivity ratio 1000:1. All subtypes are blocked equally. So it's an alpha 1 blocker. It will block sympathetically mediated vasoconstriction, so there can be fall in blood pressure. But only mild tachycardia is seen. In other than compared to phenoxybenzamine, the tachycardia is mild. Why? Because এটা কিন্তু alpha 2 receptor কে block করছে না. So it is not hampering with the catecholamine release from the prejunctional neuron. So the tachycardia is mild. It dilates arterioles more than vein. So postural hypotension is less marked compared to phenoxybenzamine. Postural hypotension is less marked but can occur in the beginning. This is a very important question. Prazosin causes first dose effect or first dose hypotension. So basically ki hoy, prazosin is a selective alpha 1 blocker. It blocks alpha 1 receptor and dilates arterioles more than veins. So postural hypotension is less marked but may occur in the beginning, causing dizziness on standing and fainting. This is called the first dose effect. How can we counteract this? We can give the drug at night time at lower dose and gradually escalate the dose. On repeated dosing, the effect gradually fades away. Other alpha blocking side effects are also milder, like meiosis, nasal stuffiness, inhibition of ejaculation. Because of milder side effects, prazosin and other alpha 1 blockers are preferred and have largely replaced phenoxybenzamine as antihypertensive. Prazosin in addition, they inhibit phosphodiesterase. Phosphodiesterase key role? They degrade basically cyclic AMP. Now, by inhibiting it, cyclic AMP concentration in the smooth muscle increases, and that is also responsible for its vasodilator action. Now, prazosin is primarily used as an antihypertensive. It can be used in benign hyperplasia of prostate and in Raynaud's disease. Higher bioavailability 90%, longer plasma half-life, more popular for use in BHP, because of single daily dose use, and it has got it for Prazosin. It is a longer acting analog. It is also a selective alpha-1 blocker, but longer acting than Prazosin. Prazosin we use twice daily. Now, because of longer action, it is used single daily dose. And number 2, it has got additional property. It promotes prostate apoptosis, prostatic cell apoptosis. It is key basically in benign hyperplasia of prostate, the prostate size start to increase. Now, because of this has got additional beneficial effect with Prazosin compared to Prazosin. This effect is unrelated to alpha-1 receptor blockade, but may retard the progression of prostatic hypertrophy. Doxazosin is another longer acting analog, longer acting alpha-1 blocker similar to Prazosin, and it has also got apoptosis promoting effect on the prostate. The drug is useful in benign hyperplasia of prostate and hypertension. Alfuzosin is a shorter acting alpha-1 receptor blocker. It has got no role in hypertension. It is used only in benign hyperplasia of prostate. Metabolism is inhibited by CYP3A4 inhibitors. Tamsulosin, এখন পর্যন্ত আমরা পড়লাম alpha-1 blocker. Now we are coming to alpha-1A selective blocker. So they preferably act on the urothelial tract. So it is relatively uroselective alpha-1A, alpha-1D blocker, as effective as Prazosin, doxazosin in patients of benign hyperplasia of prostate, but it lacks prostatic apoptosis promoting property. It has got no role in hypertension. These drugs are preferably used in benign hyperplasia of prostate. Now, the problem, the side effects, postural hypotension can be there, but it is infrequent. Dizziness and retrograde ejaculation are the only significant side effects. So, mainly 2 side effects are important, clinically important. One is postural hypotension and one is impotence. Floppy iris syndrome can be seen in patients taking Tamsulosin on cataract surgery. Now, silodosin, like Tamsulosin, silodosin is also alpha-1A selective, alpha-1A selective blocker developed in Japan. It is used for the treatment of benign hyperplasia of prostate. Postural hypotension is low with this drug compared to Tamsulosin, but failure of ejaculation is frequent, more frequent than Tamsulosin. Uses of alpha blocker, number 1, Pheochromocytoma, number 2, hypertension, number 3, benign hyperplasia of prostate, peripheral vascular disease, and it has got a role in Phentolamine induced penile erection therapy in impotence. So, Pheochromocytoma is a tumor of adrenal medullary cells where excess catecholamines are secreted within the body. It is diagnosed by estimation of urinary catecholamine metabolites, VMA, metanephrines and others. In addition, Phentolamine test can be done. Phentolamine is an alpha-1 blocker. 5 mg is injected intravenously over 1 hour. If there is fall in blood pressure more than 35 systolic and or more than 25 diastolic is diagnostic or indicative of Pheochromocytoma, but the drug test is less reliable. Many false positive and false negative results can be seen. What the treatment of Pheochromocytoma? The mainstay of treatment is surgical removal of tumor, but before surgical removal of tumor, the alpha blocker Phenoxybenzamine is given orally for 1 to 2 weeks preoperatively and intravenously given during surgery. Why? This is because while handling the tumor, there is outpouring of catecholamines in the blood intraoperatively, that can lead to severe hypertensive crisis. Number 1. So, to counteract that, the alpha blocker is used preoperatively and intraoperatively. Number 2, due to the excess catecholamine in the body due to the disease, there is shift of fluid from vascular to the extravascular compartment. So, the blood volume is decreased. So, blood volume decreased and again excess outpouring of catecholamines can lead to drastic fall in blood pressure. Now, if we preoperatively treat the patient with alpha blocker, we restore the blood volume so that intraoperatively less fall in blood pressure can be seen. Phenoxybenzamine can be also used as definitive therapy in inoperable cases and in malignant Pheochromocytoma. Prazosin is an alternative. It has already hoyeche. Now coming to hypertension. Hypertension, alpha blockers other than selective alpha 1 have been a failure in the management of essential hypertension. Why? Because vasodilatation is compensated by cardiac stimulation. Now, postural hypotension, impotence, nasal blockade and other side effects are unacceptable with non-selective blockers. However, phentolamine, phenoxybenzamine are of great value in controlling blood pressure in patients with Pheochromocytoma, in patients with clonidine withdrawal and cheese reaction. Now coming to benign hyperplasia of prostate, there is basically increased size of prostate. Now what happens in patients of BHP? There is urinary symptoms. Patients have got urinary urgency, increased frequency of urine, nocturia and others. The problem is basically there are two components. One is static component, due to increase in size of prostate, there is increased outflow obstruction of urine. Number 2, dynamic component. The smooth muscle in the bladder base and in the prostatic tissue, the tone is increased and as a result urinary obstruction occurs. Now alpha-1 adrenergic blockers like Prazosin, they basically counteract the dynamic component. They decreases the tone of the smooth muscle in bladder base and in the prostatic tissue and increases the flow of urine. And while 5-alpha reductase inhibitors like finasteride, dutasteride, they arrest growth or size of the prostate and they basically counteract the static component. They are helpful in more complete emptying of urinary bladder in patients of BHP. Voiding symptoms are relieved better than irritative symptoms. The effect with the alpha blockers is seen within 1 to 2 weeks of start of therapy, but lasts till the drug is given. When the drug is stopped, the basically improvement is not seen. So the alpha-1 blocker afford faster and greater symptomatic relief than 5-alpha reductase inhibitors. While 5-alpha reductase inhibitors, they take some time, at least 6 months is seen to see the improvement in the prostatic size. Alpha-1 blockers, they do not affect the prostatic size, effect lasts only till the drug is given. Benefit may decline after few years because the prostatic size gradually increases. They may be used concurrently with the finasteride. Terazosin, doxazosin, alfuzosin and tamsulosin are preferred blockers. Tamsulosin appears to cause fewer vascular side effects. Now, these were all about the alpha blockers. Coming to the beta blockers. Beta blockers, as the name suggests, they antagonize the beta receptors. So, these are the drugs that inhibit adrenergic responses mediated through beta receptors. All are competitive antagonists. Now, propranolol is a non-selective beta blocker. Non-selective means it inhibits both beta 1 and beta 2 receptors, but has got weak activity on beta 3 subtype. It is also an inverse agonist at beta receptor, reducing resting heart rate as well. Now, these are the classification of the beta blockers. Beta blockers can be non-selective, acting on beta 1 plus beta 2. It can be selective, cardioselective, acting only on the beta 1 receptor. So, among the non-selective, the drug can be without intrinsic sympathomimetic activity. The drug can be with intrinsic sympathomimetic activity, and the drug can have additional alpha blocking property. Intrinsic sympathomimetic activity means basically the drug is blocking the beta receptors, but again it has got some sympathomimetic activity, increases the heart rate. Normally what does beta blockers do? They decrease the heart rate, but here the bradycardia is less marked. So these drugs can be used in patients of sick sinus syndrome. So non-selective beta blockers without intrinsic sympathomimetic activity, propranolol, sotalol, timolol. Propranolol is a prototype drug. With intrinsic sympathomimetic activity, only one drug is there, pindolol, and alpha plus beta blocker combined, labetalol and carvedilol. Cardioselective beta 1 blocker, these are metoprolol, atenolol, acebutolol, bisoprolol, esmolol, betaxolol, celiprolol and nebivolol. এগুলোকে নাম কিন্তু মুখস্থ রাখতে হবে, ঠিক আছে? Now beta-adrenergic blocking drugs can again be divided in different generations. First generation, these are basically non-selective beta blockers, that means propranolol, sotalol, timolol, pindolol, labetalol, carvedilol আসবে না, সরি, এই চারটে ড্রাগ কিন্তু ফার্স্ট জেনারেশনে আসবে। Now coming to second generation, these are cardioselective beta blockers. All cardioselective beta blockers will come here. Now except some drugs. Now in third generation, what happens? Other than beta blocking property, either they have got alpha blocking property or they have got vasodilatory property additional. So there it will be seen labetalol and carvedilol, again nebivolol, betaxolol and celiprolol can be seen. They have got vasodilatory property. Pharmacological action of beta blockers, it can act on the heart, blood vessels, respiratory tract, CNS. It can act as local anesthetic, metabolic effect, skeletal muscles, eye and uterus. Coming to the heart, what does beta blocker will do on heart? It will decrease the heart rate because it antagonizes beta 1 receptors, and it will decrease the force of contraction. Heart rate কমলে, force of contraction কমলে কি হবে? Cardiac output কমবে, cardiac output কমলে কি হবে? Systolic blood pressure fall করবে. So it decreases heart rate, force of contraction, but the effect is mild on a normal resting subject. Effect is more prominent in a patient having sympathetic overactivity like exercise, emotion. Congestive heart failure may be precipitated or aggravated. It has been seen in patients with reduced cardiovascular reserve. What is seen? The dilatation of the ventricular chambers, and that can either precipitate or aggravate the congestive heart failure. So the drug has to be used cautiously in patients of congestive heart failure. Cardiac work and oxygen consumption are reduced as the product of heart rate and aortic pressure decreases. Cardiac output টা কমছে, তাহলে কি হবে? Basically heart rate টা কমছে, force of contraction কমছে, তাহলে cardiac work টা কমলো, oxygen consumption টা কমলো. Total coronary flow is reduced, but that is more marked in the subepicardial region, less marked in the subendocardial region, and the ischemic zone generally occurs in the subendocardial region. So there is beneficial flow of blood to the ischemic zone. Total coronary flow is reduced because of blockade of dilator beta receptors, but this is largely restricted to the subepicardial region, while the perfusion of the subendocardial region, which is the site of ischemia in angina pectoris, is not affected. So the overall effect is improvement in oxygen supply and demand. Got a beneficial effect in the patients of stable angina pectoris. They increase the exercise tolerance. AV conduction is slowed in the myocardial fibers. Refractory period is abbreviated, so it decreases automaticity. Now there is reversal of vasomotor reversal of Dale. তার মানে কি? Vasomotor reversal of Dale কি করছিলাম আমরা? Vasomotor reversal Dale কি? After giving alpha blocker, when adrenaline is injected, after some time they fall in blood pressure instead of rise. দ্যাট ইজ ভ্যাসোমোটর রিভার্সাল অফ ডেল। এগুলো কিন্তু পরীক্ষাতে খুব ইম্পর্টেন্ট কোয়েশ্চেন রয়েছে, পরীক্ষাতে প্র্যাকটিক্যালে। দ্যাট ইজ ভ্যাসোমোটর রিভার্সাল অফ ডেল। নাও রিভার্সাল অফ ভ্যাসোমোটর রিভার্সাল মানে কি, এখানে অ্যালফা ব্লকার জায়গায় আমরা বিটা ব্লকার দেবো। বিটা ব্লকার দিয়ে যদি অ্যাড্রিনালিন ইনজেক্ট করি তাহলে কি হবে, instead of fall only there will be rise in blood pressure, that is reversal. No direct effect on the blood vessels. On prolonged administration, BP gradually falls in hypertensive patients. Total peripheral resistance is initially increased. কেন বাড়বে? টোটাল পেরিফেরাল রেজিস্ট্যান্স কেন বাড়বে? বিটা 2 অ্যাকশন কি আছে? ভ্যাসোডাইলেটেশন। নাও বিটা 2 ব্লক করে দিচ্ছি, তাহলে ভ্যাসোকনস্ট্রিকশন হবে। ভ্যাসোকনস্ট্রিকশন মানে টোটাল পেরিফেরাল রেজিস্ট্যান্স ইজ ইনক্রিজ অ্যান্ড কার্ডিয়াক আউটপুট ইজ রেডিউসড। কার্ডিয়াক আউটপুট কমলো মানে সিস্টোলিক ব্লাড প্রেশার কমলো। টোটাল পেরিফেরাল রেজিস্ট্যান্স বেড়েছে মানে কি হবে, ডায়াস্টোলিক ব্লাড প্রেশার রাইজ করবে। সো দেয়ার ইজ বেসিক্যালি লিটল চেঞ্জ ইন ব্লাড প্রেশার, দুটো অ্যান্টাগনাইজ করছে। উইথ কন্টিনিউড ট্রিটমেন্ট কি হবে, টোটাল পেরিফেরাল রেজিস্ট্যান্স again tends back to normal because of hemodynamic adjustment. So both systolic and diastolic blood pressure falls gradually to some extent, and there is fall in blood pressure with chronic use of beta blockers. Blood vessel, other mechanism which contribute to antihypertensive actions are: number 1, reduced noradrenaline release from sympathetic terminal. It blocks the beta 2 receptor in the presynaptic neurons and thus decreases the sympathetic outflow. Number 2, decreased renin release from the kidney. Beta 1 receptor juxtamedullary cells se ache kidney te, and because of blocking at that site, renin release will decrease. There will be less sodium and water reabsorption. Central action reducing sympathetic outflow. Now respiratory tract, bronchial muscle tissue te beta 2 receptor ache. Now giving beta 2 beta blockers will cause bronchoconstriction. This is not of any clinical importance in normal individuals, but in patients of asthma or COPD, severe bronchoconstriction can occur, can lead to severe health crisis. Now central nervous system, generally no overt central effect is seen. Propranolol, it suppress anxiety in short term. Propranolol basically কি করছে, নন সেলেক্টিভ বিটা ব্লকার, বিটা 1 রিসেপ্টর অন হার্ট কাজ করছে, প্যালপিটেশন গুলো কমিয়ে দিচ্ছে, প্লাস ডিউ টু বিটা 2 অ্যাকশন ট্রেমারটা কমে যাচ্ছে। সো ইট ইজ বেসিক্যালি হেল্পফুল ইন ডিক্রিজিং দি সোম্যাটিক সিমটম অফ অ্যাংজাইটি নিউরোসিস, বাট ইট ডাজ নট অ্যাফেক্ট দ্য ডিজিজ পার সে। লোকাল অ্যানেস্থেটিক, propranolol has got additional membrane stabilizing action because of sodium channel blockade. So it's a potent local anesthetic, but is generally not used as local anesthetic. Why? Because of its irritant property, and number 2, topical instillation of the beta blocker, basically due to poor lipid solubility, it does not cross the cornea. Metabolic effect, now it can cause lipolysis. Basically we know adrenergic drugs, they cause lipolysis because of action on beta 3 receptor and beta 2. Now we are blocking basically beta 3 receptors via propranolol and beta 2 receptors, so there is decrease in free fatty acid level, triglyceride level will increase, LDL by HDL cholesterol ratio will increase. So dyslipidemia is seen with the use of drug. Number 2, in the liver, glycogenolysis occurs because of adrenergic drugs or basically sympathomimetic drugs. Now it is blocking glycogenolysis. So what happens, recovery from insulin hypoglycemia can be delayed. Now it's a very important question, why beta blocker are contraindicated in diabetic subjects. তার মধ্যে একটা কারণ এটা আছে, কি কারণ আছে, normally what does beta receptor cause, it causes glycogenolysis in the liver and the skeletal muscle, and when we are giving beta blockers, this glycogenolysis is blocked, so there will be lesser outpouring of glucose in the blood. Now when there is hypoglycemia caused due to oral hypoglycemic agents or due to insulin, the delay the recovery from the hypoglycemia is delayed, is the number 1 cause. Number 2 cause is when how we understand the patient is suffering from hypoglycemia. There is adrenergic stimulation. So, patient have tremor, patient have palpitation, increased sweating. Now, with the use of beta blockers, all these effects are blocked. So, what we are not able to understand that the patient is having hypoglycemia and severe hypoglycemia can ensue. So, beta blockers are not preferred in diabetics. These are the 2 causes. Also, beta blockers, they cause basically they convert pre-diabetic patient to diabetes because of impaired carbohydrate tolerance. Now, skeletal muscle, they inhibit propranolol, inhibit adrenergically provoked tumor mediated by beta 2 receptors. Propranolol also tend to reduce exercise capacity by attenuating beta 2 mediated increase in blood flow. Beta 2 receptor blood flow বাড়াচ্ছিল, beta blocker দিলে blood flow টা কমে যাবে. So, reduced exercise capacity as well as by limiting glycogenolysis and lipolysis, which act as a fuel for exercising muscles. I, intraocular pressure is lowered due to decrease in the secretion of aqueous humor. There is no consistent effect on the pupil size or accommodation. Uterus, normal uterine activity is not significantly affected. Coming to pharmacokinetics, propranolol is well absorbed orally, but it has got very high first pass metabolism. So, one drug having very high first pass metabolism, one is propranolol. Oral is to parenteral dose ratio is up to 40:1. Also, there is inter-individual variation in first pass metabolism of the drug. The drug is lipophilic and hence can penetrate the brain. Metabolism of propranolol is dependent on the hepatic blood flow. Now, what happens on chronic use of propranolol decreases the hepatic blood flow. So, its own bioavailability is increased and half-life is prolonged in patients on chronic use of propranolol. Bioavailability is higher when taken with meal because food decreases its first pass metabolism. Metabolism of propranolol is saturable. So, with very high dose of propranolol given, there is higher bioavailability and prolongation of half-life. Now, more than 90% of propranolol is bound to plasma proteins. Interaction, as we know that it decreases the heart rate, it decreases the force of contraction. So, additive depression of the sinus node and AV conduction with digitalis and verapamil, number 1. Number 2, as said earlier, it delays the recovery from hypoglycemia and also the warning signs of hypoglycemia are suppressed. So, the drug is not given in diabetic subjects. Phenylephrine, ephedrine, these are some of the compositions alpha agonist that is present in the cough syrup remedies. Now, these drugs can cause marked rise in blood pressure due to blockade of sympathetic vasodilatation. A patient on beta blocker, if basically if alpha agonists are given, what will happen? There will be severe rise in blood pressure. Indomethacin and other non-steroidal anti-inflammatory drugs. These are the drugs that are used to relieve pain and inflammation. Attenuate the antihypertensive action of beta blockers. Propranolol, they retard lidocaine metabolism. Now, adverse effect, number 1, these can accentuate myocardial insufficiency and precipitate or aggravate congestive heart failure. Already aage bolechi amra. So, by blocking the sympathetic support to the heart, especially during cardiovascular stress, যখন adrenergic overactivity থাকবে. Now, however, when compensation have been restored in patients of compensated heart failure, careful activation of certain beta 1 blockers is now established therapy to prolong survival. So, a patient of congestive heart failure, one of the drug for prolonging survival is beta blockers, very important drug. But these drugs should not be given in decompensated heart failure, that can aggravate the heart failure. After the heart failure is controlled, patient is asymptomatic, we introduce the beta blocker at a lower dose and gradually up titrate the dose. Bradycardia is the most common side effect Resting heart rate may be reduced to 60 per minute or less. It is more seen in patients with sick sinus syndrome. Propranolol worsen COPD can precipitate life-threatening attack of bronchial asthma. So, these drugs are contraindicated in asthmatic patients. But if in asthmatic or COPD patient beta blocker is necessary, then cardio-selective beta blocker can be given cautiously. Propranolol should not be given, or a beta blocker should not be given in vasospastic angina or variant angina, because the major pathology is vasoconstriction, coronary vasoconstriction. Now, if we use propranolol or other beta blockers, the vasoconstriction will increase further. Propranolol is better avoided in diabetics, already discussed. Plasma lipid profile is altered on long term use, already bole chi. Withdrawal of propranolol after prolonged use or chronic use should be gradual. Why? If we suddenly withdraw the drug, there will be severe hypertensive crisis, or angina may deteriorate. Why? Because on prolonged use, there is upregulation of beta receptors, and when we suddenly withdraw the drugs, the catecholamine present in the body, they act on the beta receptors. Beta receptors are more in number, so there will be severe hypertensive crisis. Propranolol is contraindicated in partial or complete heart block. Tiredness and reduced exercise capacity may be felt. Now, peripheral vascular disease is worsened because of beta blocking effect. There is vasoconstriction, so peripheral vascular disease will worsen. Side effects not overtly due to beta blockade are GIT upset, lack of drive, nightmares, forgetfulness, mental depression and sexual desires. Other beta blockers, there can be cardio-selective beta blockers, partial agonistic beta blocker, membrane beta blockers having membrane stabilizing activity, and beta blocker with low lipid solubility. Coming to cardio-selective beta blockers like metoprolol, atenolol, bisoprolol, nebivolol. Now, cardio-selective beta blockers are more potent in blocking beta-1 receptors, not the beta-2 receptors. So, lower propensity to cause bronchoconstriction. So, in asthmatic or COPD patient, if a beta blocker has to be given necessary, then cardio-selective beta blocker is preferred. They are safer in diabetics. Why? Because the adrenergic systems are not blocked. There is no beta-2 receptor, so no tremor, and recovery from hypoglycemia is not delayed. Lower incidence of cold hands and feet, no beta-2 blockade, so lesser chance of precipitating Raynaud's phenomenon. Lipid profile derangement is not seen generally with cardio-selective beta blocker. They are ineffective in suppressing essential tremor. Less liable to impair exercise capacity. Now, partial agonistic beta blockers, these drugs themselves activate beta-1 and or beta-2 receptors submaximally. Bradycardia and depression of cardiac contractility at rest is not so much prominent. Withdrawal is less likely to exacerbate hypertension or angina. These are advantages with cardio-selective beta blockers with partial agonistic activity. Now, plasma lipid profile is not worsened, not effective in migraine prophylaxis, and not suitable for secondary prophylaxis of MI. Heart rate ta komche na, so beneficial effect otota nei. Membrane stabilizing activity due to sodium channel blockade that account for its local anesthetic effect. So, anti-arrhythmic action, but appears to be insignificant. They cannot be used topically for glaucoma because the sensation of cornea is decreased. Low lipid solubility include atenolol, celiprolol, bisoprolol and sotalol. So, low lipid solubility, they cannot cross the blood-brain barrier. Less likely to cause sleep disturbance, nightmares or mental depression. They are incompletely absorbed orally. They do not undergo significant first pass metabolism. So, half-life is longer, 6 to 20 hours. They tend to be effective in narrow dose range. Sotalol is a selective beta blocker, non-selective beta blocker. They have got additional anti-arrhythmic action. because of blockade of delayed rectifier potassium channel. So, they have got effect on the cardiac rectifier potassium channel, and they are class 3 anti-arrhythmic drugs. It is a non-selective beta blocker with low lipid solubility. Timolol, due to the corneate কোনো anesthetic action নেই, timolol is the only beta blocker. So, it is the first ocular beta blocker to be used topically in patients of glaucoma. Pindolol is a beta blocker with prominent intrinsic sympathomimetic activity. Advantages in patients who develop marked bradycardia on beta blockers with propranolol. Chances of rebound hypertension on withdrawal are also less. Plasma lipid profile generally does not worsen. Metoprolol, it is cardioselective beta blocker prototype having also inverse agonistic activity on beta 1 receptors. Because of cardioselective beta 1 blocking property, it does not generally exacerbate bronchoconstriction seen in COPD and asthma patient who complain of cold hands and feet on propranolol therapy can be prescribed metoprolol or other cardioselective beta blockers. First pass metabolism is less marked. These drugs are hydroxylated by CYP2D6. Pharmacogenetics পড়েছো? So, there is also pharmacogenetics involvement with this drug. There are fast hydroxylators of the metoprolol, there are slow hydroxylators of the metoprolol because of CYP2D6 allele. Side effects are milder. It is generally given orally for hypertension, for angina, for congestive heart failure, and even intravenous injection has been used in MI provided bradycardia is absent. Now, atenolol is again a cardioselective beta blocker, incompletely absorbed orally, first pass metabolism not that significant, side effects related to CNS are less likely, no deleterious effect on lipid profile is seen, used in hypertension, angina, not approved for congestive heart failure. Congestive heart failure কিছু কিছু ড্রাগ যেটা অ্যাপ্রুভড আছে সেটা হচ্ছে কার্বেডিলল, দ্যাট ইজ বিসোপ্রোলল, দ্যাট ইজ সাস্টেইনড রিলিজ মেটোপ্রোলল অ্যান্ড নেবিভোলল. Acebutolol, it is basically cardioselective beta 1 blocker with significant partial agonistic and membrane stabilizing action. Side effect profile is like that of metoprolol, but resting heart rate is not decreased as such. কেন? Because of prominent intrinsic sympathomimetic activity. Rapidly metabolized to an active metabolite diacetolol. Bisoprolol is a cardioselective beta 1 blocker lacking intrinsic sympathomimetic activity, role in angina, hypertension, congestive heart failure. Esmolol is an ultra short acting beta blocker used intravenously. Half-life around less than 10 minutes. Action terminate in 15 to 20 minutes. So, it is used in patient to terminate supraventricular tachycardia in emergency condition. So, it is used to terminate supraventricular tachycardia, to terminate episodic atrial fibrillation, atrial flutter, and arrhythmia during anesthesia. They are also useful in decreasing heart rate and BP in patients of cardiac surgery, in aortic dissection, and in early treatment of MI. Nebivolol is the third generation cardioselective beta blocker having additional vasodilatory action. They delay atherosclerosis, absence of deleterious effect on absence of deleterious effect on plasma lipid and on carbohydrate metabolism. Celiprolol, it has got cardioselective beta 1 blocker. They have got additional beta 2 weak agonistic activity. Beta 2 bronchial tissue thake. So, if a beta blocker has to be given in asthma, celiprolol can be preferred because of weak beta 2 agonistic activity.